So hello friends, I hope I'm audible and visible. Can you all give me a quick thumbs up if my audio video is fine? Let me just check if you all can hear me properly and if my audio video is fine. So let's start with the today dermatology session with me, Dr. Chesta Aggarwal, your NEET PG educator on the best online platform. Now I have scored All India rank NEET PG 2023. Just give me a second. I hope yes, I hope my audio video is all fine. Can everyone give me a quick thumbs up if my audio video is fine? Yes. So let's start with today's session. My name is Dr. Chesta Aggarwal. Currently, we are giving you a 20% discount on all the subscriptions of Unacademy. I request everyone to please use my code CHESTA10 and get your subscription today. We have a target NEET PG batch starting on 2023, which is for the batch is starting in June. The next is we have a NEET PG 2023 repeater batch. The batch is starting soon on 1st of July, and we are expecting a price hike soon. So I request each and every one of you to kindly go ahead and get your subscription today. We also provide, or we have also given you the NEET PG subscriptions, so kindly use it. Am I audible and visible to all my dear students? So let's start with the first question of the today's session. Let's start with the first question of the today's session. Am I audible and visible? Yes, good. So what is the correct answer of this question? Arrange the following structure in skin in order of top to bottom from the most superficial one to the deeper one. Please tell me the correct answer. The correct answer of this question is, please remember the sequence which is present. Most superficial is desmoglein, number 1, followed by hemidesmosome, number 2. Then we have laminin, number 4, and then we have collagen 7, that is number 3. The correct answer is option number 4. The correct answer is option number 4. 1, 2, 4 and 3. Pick the parts of desmosome. Anyone can tell me the answer here? Pick the parts of desmosome. Pick the parts of desmosome. Now please remember, desmosome is made up of desmoglein, desmocholine and plakophilin. Laminin is not the part of desmosome. Laminin is a part of basement membrane. And that is why the correct answer of this question is option number 1. Is that clear to all of you? The correct answer of this question is option number 1. Can I get a quick thumbs up from all of you? Moving to the next part. Check the histopathological term and their associated disease. Check the histopathological term and their associated disease. Colloid body erythema multiforme, epidermotrophism, subcutaneous mycosis, spongiosis, eczema, parakeratosis, lichen planus. Which of the following is the correct answer? Which of the following is the correct answer? Anyone? Anybody can tell me the answer here? Please remember, colloid body is nothing but the degenerated stratum basale. So erythema multiforme, this is correct. Even in lichen planus, this is nothing but the degenerated stratum basale. Spongiosis is a feature of eczema, this is correct. Epidermotrophism is a feature of cutaneous T-cell lymphoma. And parakeratosis is a feature of psoriasis, not lichen planus. So please remember the correct answer of this question is number A and C. Number A and C. Is that clear to all of you? Now let's move to the next question. What is the correct answer here? What is the correct answer? A patient with blisters on the skin. His Zinc smear shows cells as shown. What is the true statement? The skin. The Zinc smear shows cells as shown in the image. What is the correct answer? Very nice. This is a very classical image of multinucleated giant cells which is seen in the patients of herpes. It is multinucleated giant cell which is seen in the patients of herpes. Whether it is herpes simplex or herpes genitalis. The diseases caused by staphylococcus are Jayashruti, Kalyani, Doraemon, Ashima. Anybody can tell me the answer here? What is the correct answer here in this question? The disease caused by staphylococcus are non-bullous impetigo, pemphigus neonatorum, erysipelas or Retter's disease. The disease caused by staphylococcus are, remember that the pemphigus neonatorum, which is nothing but bullous impetigo, and Retter's disease, which is nothing but staphylococcal scalded skin syndrome. Bullous impetigo or staphylococcal scalded skin syndrome, they are exclusive of staphylococcus. So the correct answer is option number 3. Is that clear to all of you? Next. Now I am giving you a hint. This is an image of bullous impetigo. Now why I am saying that this is a patient with bullous impetigo? What is that feature here? You can see that there is turbid fluid which is present. Whenever you see the turbid fluid containing vesicles, always think of infectious cause. And here, because it is yellow and you can see that he is a small kid, so this is a bullous impetigo lesion. What is the correct answer here? Which of the following statement regarding the image is true? The answer is option number 2. Now we have discussed that this is a patient with what? This is a patient with bullous impetigo. Now remember that in bullous impetigo, the regional lymphadenitis is not very common. It is more common with non-bullous type of impetigo. You see intraepidermal bulla, this is true. You see Warnish crust and you see exclusive lesions by Staph aureus, but not regional lymphadenopathy. Next question is on your computer screen. A farmer developed a single papule on his left index finger within a week of handling his goat. Papules enlarges into a hemorrhagic bulla and healed after 3 to 6 weeks. The lesion was diagnosed to be an off infection. Identify the incorrect statement regarding the diagnosis. Also known as Ichthyma contagiosum. It is also known as Ichthyma contagiosum. Now, Ichthyma contagiosum is because of parapox virus. It is because of parapox virus, not Coxsackie virus. This is wrong. No specific antivirals are seen. That is true. And ballooning degeneration is seen. That is also true. The only incorrect statement which we have is option number 2. So that is the false statement regarding the diagnosis. I hope this is clear to all of you. Can I get a quick thumbs up? You can see the lesion. It is mainly present on the fingertip. viral infections or virus, parapox or direct contact infections. Clear? Another question is on your screen. Harsha, Jayashruti, Ashima, Kalyani. Please read the question carefully. The question says that we have a 2-month-old infant. We have a 2-month-old infant who develops otitis media, for which he was given a course of cough. A few days later, he developed fever, irritability, skin tenderness, but the mucosal lesions were not seen. All these features points towards the diagnosis of staphylococcal scalded skin syndrome. Now I want all my students to please look at this image. Can you see that the skin is just peeling off without any effort, like a potato skin, as if you are removing the skin of the potato. It is just going out. So please remember, this is a very, very classical image of staphylococcal scalded skin syndrome. Can you tell me the answer here? This is a assertion reason type, will not get much questions in FMG paper, but just try to answer this so that your concepts will get clear. Anyone? So there's a lot of disturbance going on right now. I don't know why the internet is coming and going. So I hope everybody can listen to me carefully. So we have a slit skin smear negative in a TT leprosy patient. TT leprosy is a paucibacillary type of leprosy. Now please give me a quick thumbs up if you know about this question. Now what is slit skin smear? It is a smear which is done to look for the acid-fast bacilli. Now acid-fast bacilli, it is negative towards the TT pole of leprosy. Can you tell me why? Because you have a very strong cell-mediated immunity. And because of strong cell-mediated immunity, you will call TT leprosy as a paucibacillary type of leprosy. How many of you agrees with me? Kalyani, Ashima, everyone? So the correct answer is option number 1. Both assertion and reason is correct for this particular question. Now you can look at this image, the steps of doing acid-fast bacilli, the slit skin smear. With the help of an index finger and thumb, you will pinch the lesion. You will get, or you will give a perpendicular nick. Here you will give a perpendicular nick. You are giving a nick and you are actually scraping the margins of the lesion. When you do a Zn stain, that is, you follow the following steps. You will apply carbol-fustin, you will apply heat, then how much is the percentage of H2SO4? 2%. And then finally the counter stain, you will see an image like this. All these structures which are pink in color, they are acid-fast bacilli, while the background of blue color is seen in the patients of leprosy. Now please tell me the correct answer of the next question. Check the MDT schedule in adult leprosy and mark the correct option. Check the MDT schedule in the adult leprosy and mark the correct option. What is the correct answer? Now it's a very interesting and easy question. If you look at this, in adult leprosy we give 600 mg of rifampicin. What is the frequency of giving this? We give it once in a month, and that is always supervised. For giving clofazimine, you give it once in a month, but you also add once a day of clofazimine. So number 1, number 2 and number 4 is correct. But Depson dose is 100 mg per day. So the correct answer is A, B and D, not C. So that is the MDT schedule. You can see the packet. These two are the rifampicin, 300 mg each, so 600 mg. Then these three are 100 mg of clofazimine, so total 300 mg. And this one is the Depson, 100 mg. Now every day patient has to take one Depson, one clofazimine, one Depson, one clofazimine. And clofazimine here is 50 mg. This red color kit is for adult leprosy. And this yellowish orange color is for MDT in children. Please remember, previously we used to give two drugs for paucibacillary, but we are not doing it now. We are only giving these two kits, red and yellow, for 6 months in paucibacillary, for 12 months in multibacillary. That is our sequence which follows. Next question is on your computer screen. What is the answer? Anyone? Ashima, Kalyani? Anybody can tell me the correct answer of this question? Now please remember, for answering these type of clinical based question, we have made a trick. What is that trick? Look at the number of lesion which is asked in the question, whether it is few or multiple. If the question says that there are few lesions, the possibility is more of TT and BT. And if they want you to tell BT as the answer, they will always mention the history of satellite lesions, which are the small sized lesions surrounding the main plaque. For multiple lesions, we have three types. BB, BL and LL. In B, you have asymmetrical. The lesions are multiple, but they are asymmetrical, more towards the one side of the body. And in lepromatous pole, they are symmetrical to each other. Both the sides have same lesions. Then how to differentiate? In BL, in addition to multiple symmetrical lesions, you will have hypoesthesia over the plaque. While in LL, there is normal sensation over the lesions. If this is clear, please give me a quick thumbs up. If this is clear, please give me a quick thumbs up. Few lesions, multiple lesions. TT, BT, and for multiple BB it is asymmetrical, BL and LL symmetrical, but you have to look for the presence of esthesia over the patch. Now I want everyone to please use that chart and try solving this question. Please use that chart and try solving this particular question here. A 45-year-old male had multiple hypoaesthetic. So now one thing is clear, that it is multiple. If they are writing multiple, we can easily rule out TT and BT. This cannot be the answer, obviously. For it to be multiple hypoaesthetic, look for the symmetry. It is present on the trunk and extremities. So this is symmetrical distribution. So we can rule out even the BB. Now we have to check between BL and LL. So you can see hypoesthesia, so you can even rule out LL. The correct answer is borderline lepromatous leprosy. Now, is this question clear to all of you? Can I get a quick thumbs up from everyone? Nice. The next question is here on your screen. Arrange the following stages of doing an auspicious sign in order of their time of occurrence in the test, from the earliest to the last. Very nice. The steps is you should have a scaly plaque first, that is the prerequisite. You will scratch them, so you will do a garrotage sign. You will remove these scales, you will see Bulkeley's membrane, and when remove this Bulkeley's membrane, you will see pin point bleeding spots. You will get pinpoint bleeding spots. So the sequence becomes A, B, D and C. The sequence becomes A, B, D and C. Sorry, A, B, D and C. Clear hai? So arrange the following stages of doing auspicious sign. The correct answer is option number 1. The next question. Please tell me the correct answer. Dermal melanin is seen in lichen planus. Wedge-shaped hypergranulosis is seen in lichen planus. Which of the following is the correct statement? Now this is true. Option number 1 is true. Obviously you see dermal melanin, and that is why the lichen planus lesions, the color is violet. It is not red, it is violet color. Okay. But the reason behind the dermal melanin is not the wedging. Both the statement is right, but they are not the explanation of each other. The reason for dermal melanin is basal cell degeneration. So when there is damage to basal cell, the pigment falls down in the dermis. So whenever you have damage to the melanocyte, the pigment falls down in the dermis. And wedging of the hypergranulosis is responsible for a very classical feature, that is Wickham's trap. So I will say that the answer to this question is option number 2. Understood, Ashima? Kalyani? Next question. This is a little difficult question if you are targeting FMG, but let's try. Match the column A with the best alternative in column number B. Match the column A with the best alternative in column number B. Very nice, all of you. Now lichen planus is associated with scarring alopecia, and please remember, scarring alopecia clinical appearance is footprint in snow appearance, also known as pseudopelade. Reactive arthritis is another name for Retter's disease. Retter's disease. Retter's disease. There is a very classical triad of arthritis, urethritis, conjunctivitis. In addition, you have keratoderma blennorrhagica and circinate balanitis. Seborrheic dermatitis, cradle cap, and pityriasis rubra pilaris, follicular keratosis. So 1 goes for C, 2 goes for D, 3 for A, and 4 for E. The answer is option number 1. Very nice, Kalyani. Absolutely right. Clear? Next question. Arrange the following lesion in order of their malignancy, which is most malignant and which is the least malignant. You have to arrange them in sequence. From most to least, you have to arrange them in sequence. Anyone can tell me the answer? Which is having more malignant potential compared to the other one? Okay. Please remember, erythroplakia has maximum malignant potential. Erythroplakia. This is followed by leukoplakia. In leukoplakia, we have two types. One is non-homogeneous, which is more malignant potential, and homogeneous. Non-homogeneous and homogeneous. And the next one is ulcerative lichen planus. Please remember, the lacy type or the reticulate type has no malignant potential. It has no malignant potential. It has no malignant potential in them. I hope this is clear to all my dear students. So what is the sequence? Number 1. Then we have number 3. Number 3. Then we have number 2 and then we have number 4. So 1, 3, 2, 4, the correct answer becomes option number 1. Clear, Kalyani, Ashima and other students? You can see the images of each of them. The commonest is leukoplakia, but the one with maximum malignant potential is erythroplakia. Maximum malignant potential. This is a patient with leukoplakia. You can see the whitish non-scrapable patch on the plaque on the surface of the palate. This is erythroplakia. You can see erosive. It is looking more scary compared to this. This is looking more benign. And this is lichen planus. And why do I say so? Because in lichen planus, you will have a very characteristic violaceous margin. You have a very characteristic violaceous margin. Okay. Am I audible and visible to all of you? Am I audible and visible? Can you say yes? Because I can see that the video is not going so smooth. Is it going smooth or there is some lag in the video but the audio is fine? Please do let me know if there is any issue, because there is some internet issues in Rajasthan right now, so that could be the reason for this problem. Am I audible and visible to everyone? Okay, so the audio is fine but the video is hanging. Okay, fine. Does it take a long time to heal? So Kalyani, you are asking this with respect to what? You are asking this with respect to that of the benign conditions or the pre-malignant conditions? Audio is fine. Okay. So let's continue with the next question. See, Kalyani, for the ulcerative type of lichen planus, you have to treat them by giving the therapies. For example, you can give steroids intralesional. Okay. I think I should restart it again because I hope this is fine now because I have restarted. What are the causes of papillosquamous lesion? The answer is except congenital syphilis. Congenital syphilis mainly presents with vesicles and bullae. And these lesions of vesicles and bullae of congenital syphilis are called as syphilitic pemphigus. So I have restarted everything. I hope you all can see this. Moving to the next question. Please tell me what is the correct answer of this question. A patient presented with erythematous scaly lesions on the extensor aspect of the elbow, knee. Which of the following statement regarding the pathophysiology of this disorder is incorrect? Anybody can tell me the answer? First of all, you should know that if there is erythematous scaly lesions on the extensor, it means we are dealing with patient of psoriasis. We are dealing with the patients of psoriasis. And please remember, in psoriasis there is increase in Th1 and Th17 cell lines. Now, what is the main problem in the patients of psoriasis? Let's see. Under the influence of a lot of factors like genetics, drugs, infections, Th1 and Th17 cell lines increases. Now these cell lines will release some interleukins, IL-12, IL-22, IL-17, IL-23. We have interferon gamma, TNF alpha. Now all these interleukins will then cause epidermal proliferation. And whenever you have epidermal, what happens? The cell cycle time reduces to 30 hours from 300 hours, and epidermal turnover time reduces to 4 days from 56 to 72 days. So Kalyani, Ashima, I hope my audio is reaching to you properly, because the video is showing some delay. But whenever you have reduction in the epidermal turnover time, the cell starts to proliferate very fast, and these rapidly proliferating cells will then form multiple layers of these scales at the top. So that is the pathogenesis of a psoriatic patient. Can I get a quick thumbs up from everyone? I'm sure that at least you are getting the audio clear. Amazing, Kalyani. Thank you. So the answer for this particular question becomes option number 3. The answer to this question becomes option number 3. Now, which is the most characteristic sign of psoriasis on histopathology? So we are on the next question right now. The most characteristic sign of psoriasis on histopath: micromunro abscess, parakeratosis, suprapapillary thinning, or elongation of regions. So I think you have to just wait for a second, because there is little delay in the audio video. So the next question, try to answer that. Amazing. What is, first of all, let me write what are these things. Micromonro abscess, collection of neutrophils in stratum corneum. What is parakeratosis? Retention of nucleus in stratum corneum. And suprapapillary means the papilla which is present above the dermal papilla is, or this epidermis above the dermal papilla is thinned, and there is elongation of rete ridges. All of these are the findings of psoriasis, but the characteristic one is micromonro abscess. Micromonro abscess is a very characteristic feature, and if a patient presents to you with collection of neutrophils in the stratum corneum, think of nothing other than psoriasis. Next question. Please answer the next question on your screen. A 30-year-old male with silvery white scales on the extensor aspect of the elbow, which of the following clinical test will aid in the diagnosis? Anyone? Very nice. The answer is Auspit sign, which is also known as Grattage test, because the step 1 of the Auspit sign is you will use a glass slide and you will rub the lesion. Very nice. See, silvery white scales on the extensors, it means we are dealing with a patient of psoriasis. So please remember, Yogesh, it is not tinea, it is psoriasis. Tinea is the disease of flexures, while psoriasis is the disease of extensors. Next. Please write down the mnemonic for drugs causing psoriasis. Mnemonics for drug causing psoriasis, and the mnemonic is PLAB. P-L-A-B. Painkiller, which is NSAIDs. Lithium, ACE inhibitor or anti-malarials, and the last is beta block. So all are the cause except for option number 4. So which of the following drug is not responsible for exacerbation of psoriasis? The answer becomes option number 4. Next. Which is not true regarding the histopathology of psoriasis? Which is not true regarding the histopathology of psoriasis? Epidermal thickening, suprapapillary thinning, Kogo's spongiform pustule, and Porteous microabscess. What is the answer? Which of the following is not true regarding the histopathology of psoriasis? Very nice. The correct answer of this question is Portreous microabscess is collection of lymphocytes in epidermis, and please remember it is a feature of cutaneous T-cell lymphoma or mycosis fungoides. Cutaneous T-cell lymphoma or mycosis fungoides. Next. Arrange the following blistering disorder in skin in order of their fluid collection from top to bottom. Very nice. In bullous impetigo, it is subcorneal, just beneath the stratum corneum. Hailey-Hailey disease, it is suprabasal, just above the stratum basal. In cicatricial pemphigoid, at the level of basement membrane, and in epidermolysis bullosa dystrophica, at the level of dermis. So the correct answer is number 4, 1, 2 and 3. 2. Clear? The correct answer is option number 2. Dermal blisters are seen in Hailey-Hailey disease, staphylococcal scalded skin syndrome, burns and bullous SLE. Dermal blisters are seen in Dermal blisters are seen in Dermal blisters are seen in. Very nice. We have just now read Hailey-Hailey, which is a blister at the level of basal or suprabasal, which is intraepidermal. Here you have subcorneal. But these two you will have dermal split. So C and D is the correct answer. Very nice. Row of tombstone appearance is seen in pemphigus vulgaris. Hemidesmosomes are not affected in pemphigus vulgaris. What is the answer? Anyone? Very nice, Ashima, Kalyani, MK, Aditya. This is a correct statement. In pemphigus vulgaris, you see intact stratum basal, which are seen standing separated from each other, but they still remain connected to the basement membrane with the help of a glue, which is known as hemidesmosomes. Hemidesmosomes, which is known as hemidesmosome. So which of the following is the correct answer? The correct answer of this is option number 1. Both of them are correct and they are correct explanations of each other. Next. The answer is option 1. In the next question, the bulla split sign is negative in pemphigus foliaceus. This is true. And the reason is because in pemphigus foliaceus, the level is so superficial that you rarely see any intact bulla. You see scales as the presenting feature, and that is why here also the correct answer is option number 1. Clear? Now please match the DIA finding of column A with the best alternative in column number B. Anyone can tell me the answer? Match the DI finding of column A with the best alternative of in column number B. Linear IgG is a very characteristic feature of pemphigoid. Granular IgA is a feature of dermatitis herpetiformis. Intercellular IgG is a feature of pemphigus, and negative fluorescence is in the infectious disorder. So 1 is for C, 2 is for F, 3 is for B, and 4 is for A. The correct answer is option number 1. You can see that in the patients of pemphigus you have intercellular IgG. Like a fish net or a chicken wire pattern. In pemphigoid you have linear band like a ribbon candy appearance, while you have granular in the patient of dermatitis herpetiformis. Next question. What is the correct answer here? We have a young boy of 8 days with no history of consanguinity. Mother reports blisters and peeling off of the skin at the handling site. Very nice. It is a mechanobullous disorder which is known as epidermolysis bullosa. 3 type: epidermolysis bullosa, simplex, junctional, and dystrophica. Okay, so very important question of mechanobullous disorder. The simplex variety, the level of split is intraepidermal because the damage occurs at keratin 514 level. In EB junctional, it is subepidermal because the problem occurs in the basement membrane zone, laminin, while in EB dystrophica the split is subepidermal because the damage occurs to what? Because the damage occurs to the collagen 7. Damage occurred to the collagen 7. If this is clear, can I get a quick thumbs up from all of you? So let's move to the next question. Tell me the answer. Anyone can tell me the correct answer for this question? The correct answer of this question is option number 2. You can see that we have a very localized lesion in an adult patient. The localized presentation gives you an idea that this is EB simplex. In EB junctional and EB dystrophic, you will see a more widespread involvement little early in the life. So that is how you can differentiate these three conditions from each other. Moving to the next question. What is the answer here? Please remember the correct answer for this question is option number 2. EB acquisita. Now, EB dystrophica, which is a type of mechanobullous disorder, and EB acquisita, which is a type of immunobullous disorder, they both present in a very similar pattern. Because the target antigen is collagen 7. In EB dystrophica, it is the gene deficiency, gene defect which leads to deficiency of collagen 7. But in EB acquisita, it is the IgG type of autoantibody which causes damage to the collagen 7. The presentation in both is same. You will have scarring, milia, and blisters on the extensors. I hope this is clear to everyone. Clear hai? Next question. What is the correct answer of the next question? Anyone? Female presented with diffuse alopecia. She had suffered from typhoid. The most probable diagnosis is telogen effluvium. We have a very similar question in NEET PG 2022. And there they have given you the history of COVID infection. So this is a patient with telogen effluvium. Next. I hope it is visible to all of you, the question. Identify the incorrect statement regarding the type of hair. Ashima, Thor, Kalyani. Identify the incorrect statement regarding the type of hair. The answer is vellus hair never extends to subcutis. It remains in the mid-dermis. So the terminal hair are long hair and broad pigmented hairs. They are long, they are thick, they are pigmented. They reach up to the subcutis. while vellus hair are thin, short, non-pigmented. Clear and thin, short and non-pigmented. Which of the following is not true about hair cycle? Which of the following is not true about? Anyone? Anyone can tell me the answer here? Which of the following is not true about hair cycle? The correct answer is, at one point of time, total 80% of the hairs are in anagen, 5% in catagen, and 15% in telogen. So the incorrect statement is option number B. Clear? The incorrect statement is option number B. Moving to the next. What is the correct answer? Diagnosis of a female with a hair loss involving the crown and frontal scalp with maintenance of the frontal hairline. Very nice. In female, if this is the scalp, the scalp margin or the frontal margin is always maintained. It is the part which get widened up. It is the part which get widened up. Okay. So the answer is female pattern, which is known as Ludwig's classification. Ludwig's classification system. Next. Anyone? Cicatricial alopecia is seen in Very nice. Answer is all of the above. Lichen planus, SLE, sarcoidosis, they are all the example of cicatricial alopecias. While the examples of non-cicatricial alopecia, we have 3 A's and 3 T's. Alopecia areata, androgenic alopecia, and anagen effluvium. While for telogen T, it is telogen effluvium. Trichotillomania and tinea capitis of non-inflammatory type. Telogen effluvium of non-inflammatory type. Non-cicatricial alopecia, 3T and 3A are the examples. Tell me what is the answer. Match the item of column A with the best alternative of column number B. Match the item of column A with the best alternative in column number B. Loss of frontal parietal hairline, chemotherapy induced hair loss, hair of variable length in alopecia patch or peribulbar inflammation. Very nice. The answer is loss of frontoparietal hair is a feature of androgenic alopecia. So 1 is for E. Chemotherapeutic is anagen effluvium. 2 is for D. Hair of variable length, this is for trichotillomania, number C. And peribulbar inflammation is for alopecia areata, number A. The correct answer is option number 1. Next question, please tell me the answer. Please tell me the correct answer here. You have non-cicatricial alopecia, itching and scaling. The diagnosis is very nice. The diagnosis is alopecia areata. Sorry, I'm very sorry, very sorry. It is not alopecia areata because you can see that there is itching and scaling. So it is the tinea capitis. Please remember, fungal infection of the scalp is more common in pre-pubertal age group. And can anybody tell me why? The reason behind this is because the sebum which is present after puberty is antifungal. So before puberty we don't have any sebum, and that is why in a pre-pubertal if you see scaling and itching over the scalp, you have to think of fungal infection of the scalp. Please tell me the correct answer here. Anagen phase of the hair indicate dash. Anagen phase of the hair indicate activity and growth. Transition is the catagen. And resting is the telogen. So the phase of the hair which indicate activity and growth is option number 1. Next question is on your computer screen. Eyebrow hairs does not grow beyond certain length as they have a short what? Very nice. The length of the hair we have just now discussed is decided by the anagen phase. So the eyebrows are shorter because their anagen phase is shorter. Is that clear? Any confusion? We have a 79-year-old patient What is the correct answer for this particular question? Anyone? It's a little lengthy question, but if I mark some highlight points. Patient has a history of contact with wet cement and the lesion disappeared when the contact with cement is removed. It means it is allergic contact dermatitis to cement, and in allergic contact dermatitis to cement, the allergen is potassium dichromate. Can anybody tell me what component we are using nowadays to prevent the cement contact dermatitis? What allergen we are using nowadays? We are using ferrous sulfate. We are using ferrous sulfate nowadays to prevent this allergy to the cement. Next question. Now this is a girl with diffuse itching. On examining the patient, there was erythematous papules throughout her body with excoriation which has waxed and waned. The itching was controlled with hydroxyzine and a potent topical corticosteroids and over-the-counter skin solutions. Can you tell me what is the diagnosis here? What is happening in this patient? So let me help you that this patient is having atopic dermatitis. The question is, what will be the topical medicines you will be using in this patient to take care of these, or for maintaining the remission of the condition? So we have different drugs for active stage and we have different drugs for maintenance phase. For active we give steroids, but for maintenance we give tacrolimus, which is the calcineurin inhibitors. The correct answer of this question is option number 1. Very nice, Ashima, Doraemon, Akash, Ashish. Next. Anybody can tell me the answer here? The image is very classical and I'll tell you what is this image called as. Raccoon's eye or panda eye. Please remember, very nice Ashima. It is the feature of primary systemic amyloidosis, where because of deposition of Benzone protein inside the bone marrow, there is thrombocytopenia giving rise to spontaneous purpuric lesions around the eyes. Next. Next question is on your screen. What is the correct answer? A patient with yellowish plaque around the eyes, it means xanthelasma pallidum. palpebrum. And for xanthelasma palpebrum, type 3 hyperlipoproteinemias are indicated. Type 3 hyperlipoproteinemias are indicated. Next question. A patient with history of diabetes mellitus since 10 years. Patient noticed that skin lesions have grew relentlessly over the upper back and these are non-pitting erythematous lesions with pudy orange appearance. What is the diagnosis? Please remember, it is a patient of scleroderma diabeticorum. Scleroderma diabeticorum. Scleroderma diabeticorum. I hope my audio video is fine to all of you. Scleroderma diabeticorum. It mainly starts on the upper back because of mucin deposition. The dermis become 3 to 4 times thick and give you an pudy orange appearance. And please remember, sclerodactyly or Raynaud's phenomena is not the feature. Sclerodactyly or Raynaud's phenomena is not the feature. Next. This will be the last question of the today's session. Anyone? Very nice, all of you. The answer is necrobiotic lipoidica. If you were present in my morning session, we have discussed this question little bit. That because of extravasation of RBCs, the red blood cells get deposited in the skin, causing the damage to the skin, giving rise to these necrotic lesions on the anterior part of the lower limbs. So with this, we are done with today's session. Again, repeating a very important offer which is currently going on Unacademy. I request all my students to kindly subscription using the code CHESTA10 because we are currently giving you 20% discount. So thank you all of you. I hope you have liked this series of a lot of MCQs. This offer is only valid till today. If anybody is interested, please take it because from tomorrow we are expecting a price hike in both Iconic as well as in Plus. So thank you all of you for your patience listening. Please stay tuned on this channel for any more details for your NEET PG INI